Welcome. Thanks for joining us today for this EMSC Collaboration Quarterly Webinar. This is our first, and with our intent to carry this out on a quarterly basis, and to be hosted by RAPM, and also as we continue to go forward, of course, partnering with our other pediatric preparedness partners. So with that, I don't see Marianne Gauchy-Hill. Going to check with her if there's any updates from her, but with that, I will go ahead and stop share. And introduce our speaker for today, Hilary Hewes, with Utah. And I'm going to let her go ahead and finish her introducing herself, because I usually stumble through that. But again, as we go forward, please, any questions you have, please post them in the chat. And at the end, we'll take some time to respond to those. And with that, I'll pass it to Dr. Hewes for her presentation today.
Thanks, everyone. Everyone can hear me okay and see the slides up? Okay. You got it, David? Okay. So I'm Hilary Hewes. I'm one of the pediatric emergency medicine physicians here in Salt Lake City, Utah, and I'm the site PI for the Utah PPN site, as well as the principal investigator with the EMS for Children Data Center. So today I was asked to talk a little bit about our pediatric emergency care coordinators, some data behind why they're so important and how we can support them, and then just a little bit about the Telesimulation outreach project I've been a part of, and that we're expanding with the help of PPN. And some of this, you guys are all probably from different audiences. Some of you may have seen some of these slides previously with RAPM or in Austin at some of the presentations. It's kind of a big mesh of information. So hopefully not too repetitive, but please speak up anytime if there's questions. So just to remind everyone what we are really talking about here, when we talk about pediatric readiness, going back to the reason we do this project, and it's first started as the National Pediatric Readiness Project, or NPRP, and the goal is to empower all emergency departments to provide effective emergency care to children. And since that time, we've obviously expanded this, and now we're going into the pre-hospital setting with the Pre-Hospital Pediatric Readiness Project, and this has become kind of a big umbrella idea of pediatric readiness. But why do we need to even have a focus on pediatric readiness? We know that there's more than 35 million annual pediatric visits to EDs across the country, and the vast majority of these occur in non-children hospitals. So some of these are hospitals that are seeing less than 10 pediatric patients a day. Some are seeing 1 pediatric patient a day in some of the smaller, more rural settings. We know that there's no universal licensing requirement, and there are variable readiness levels to meet the needs of children. We also know, when we look at the data that was collected through the 2 big national NPRP assessments in 2013 and 2021, that there's a lot of variability in how people are approaching pediatric emergency care, even with things like, do people do quality improvement? Do they look at their processes in their ER? Do they do chart review? And we know even as recent as 2021, less than 50% of EDs say they do pediatric QI. We also know from work that was done by previous researchers that 94% of children live less than 30 minutes of any emergency department, but only 55% live within 30 minutes of one of those higher levels, so those top quartile PEDS-ready EDs, and 90% live closer to what we would call a non-PEDS-ready ED. And that's based really on, do you get into that top level of quartile of your pediatric readiness score that's been shown to have a decreased mortality? So if you we'll talk a little bit about this later on, but if you present to one of these ERs that scores in the highest quartile, so the highest group of ERs, you're less likely to die as a child than if you present to an ER in the lower quartile. So a lot of this data comes from that most recent pediatric readiness assessment that was done in 2021. And in that assessment, we reached out to all 5,000 plus ERs that are open 24/7 across the United States and the free territories. And we found that the response rate was about 70%, which was pretty great because this was still kind of in the midst of COVID. And you can see this was our final response rate map. And just some major highlights from the 2021 assessment, just looking at the big picture, we were really excited about engagement in pediatric readiness because a 70% response rate was fantastic. That's higher than most people get for big surveys. And especially, again, with the stress of COVID, we thought that was really great. we see that emergency care, unfortunately, still remains uneven. And that quote comes from the 2001, I think, Institute of Medicine report that first kind of called out the need to improve this emergency care for children across the continuum of care. That, we always kind of focused on adults, and we didn't have a lot of processes in place for children. And we still see that there's a lot of gaps there. And we felt that until pediatric readiness becomes policy, things like having a pediatric emergency care champion and doing quality improvement remain some of the best drivers for pediatric emergency care transformation. We feel like that's a way that you can really make a difference in how well your ER is performing. And we also found that pediatric readiness is a roadmap to address some of these issues of health disparity. And I think we have a slide about that later, but there's a study that shows if you get into that higher quartile of pediatric readiness, the gap shrinks between outcomes for children who are white versus Hispanic, Latino, and Black. So in those lower quartiles, there's these big gaps in mortality, and that shrinks as you get into those higher levels. So increasing pediatric readiness also helps to address some issues of health disparity. So when we look at the landscape overall, 2020 or 2013 versus 2021, one thing I know we're all aware of, this affects all of us, no matter where we live, is the closure of rural and remote EDs. And with that, the closure of some of the inpatient units. So I'm having trouble getting this thing to go away so I can actually see all my slides. Let me see if I can figure out how to do it. Sorry, let me go back there. Well, we're just gonna wing it. Okay, so the majority of, sorry, does anyone know how to hide the chat or the people? I just can't see the edge of my slides, but okay. So sorry, I keep going back and forth. So you can see that this is kind of the breakdown of where EDs are found when we do what's called geocoding. So we look at the zip code and they're assigned one of these codes, one of these urbanicities, depending on their zip code. So a lot of kids, or a lot of ER still are present in rural remote, but there's been some change over time when you look at where they're present. And then you can see here still the majority of children are seen in those, or the majority of ERs have a general ED configuration, meaning they don't have a separate pediatric ER space. And then this is one thing, again, we're all aware of, and this has caused some downstream effects, are the closures of inpatient wards. So 17% fewer hospitals reported availability of pediatric inpatient wards between 2013 and 2021. This is in part due a lot to loss of critical access hospitals over the past decade, and with that loss of other inpatient units. So I think we all felt this effect, especially during that respiratory surge last year. We had not only less beds available for patients, but we also had less experience. So when you lose a pediatric patient ward, you lose that nursing experience, you lose that respiratory therapist experience, you lose the ability to have those people who feel comfortable recognizing a sick kid and treating a sick kid and being familiar with the equipment. So it's not just the bed space you lose, but you also lose that knowledge base and that experience. That's something that comes, but when we come back to the PECC concept, that's something that a PECC can help do, is really help, even if there's not an inpatient ward, making sure that people still feel comfortable with kids and are practicing skills with kids. And then we look at the overall big picture here of how are we doing with policies and procedures. So all of these, if you guys aren't familiar with the pediatric readiness assessment, there's different questions that are broken down into domains. And one of the big domains is looking at, do you have these certain policies or procedures in place, and looking at safety issues. So things like weighing children in kilograms and having a triage process where you would flag a child who has abnormal vital signs, and then having a stated policy where you have to go back and assess and reassess patients who had abnormal vital signs. Those all fall into some of those policies and procedures under safety. And you can see that we have made some good improvement in those realms over time, especially the weight in kilo. And we do have some improvement as well in some other policies that we think affect children's health and family health overall. So things like, do we have a policy to deal when the child dies in the ER, to provide support for family, to do some of those memory things we do with handprints? Do we make sure that we're reducing dose radiation for CTs as much as possible. You know, mental health and behavioral health is something we're all struggling with across every ED in the country. So do we have policies in place to help assess children with mental health conditions and expedite transfer? And so we have made a lot of progress in those specific categories. And then you can see down here in green, we still are doing fantastic, making sure we have a good percentage of the recommended equipment carried in each ED. This is kind of this little box in gray over here. We asked specifically about, do you require your staff to have pediatric specific competencies to be tested on pediatric specific things like sedation policies or use of skills or CPR or whatever it may be. And you can see it's pretty variable. So nursing seems to be the most heavily tested and most consistent, and then physicians and advanced practitioners a little bit less so. So again, maybe that missing piece of, are we every now and then checking in with our staff to make sure that they're keeping up and doing the things they're supposed to be. So we mentioned the weight and the importance of having a quality improvement plan, and it doesn't only affect your score, but we really feel like it affects the quality of care that you're giving to your kids when they come into an ER. So having a quality improvement plan in place and having a full plan, meaning you have all of the elements that we feel really make up good quality improvement. And if you have that in place, you get an average of 26 point higher in your adjusted weighted pediatric readiness score compared to if you don't have a QI plan in place. And it really shifts you from that lowest quartile up to that top quartile, which is where we see that mortality and outcome difference in children. And you know, the points awarded for having the QI plan isn't a ton. It's, I can't remember off the top of my head, but maybe 6 points, but having that in full then pushes you 26 points up. And I think it's a reflection that you have the infrastructure in your ER, you have people who are dedicated to making change and examining processes, and probably you have a PECC who's helping lead that charge in terms of making sure we're looking at how outcomes are with kids and what needs to be improved and reviewing cases to find gaps. Okay, so I'm going to pause for a sec. That was just some of the background information. But before we dive into really the most important subject about PECCs, anyone, I can't see the chat. So if anyone has put any questions in, if they want to shout them out.
I don't see any questions in the chat yet, but by all means, if you have one right now, just unmute yourself and let us know.
All right, so, oh, sorry, I didn't mean to announce that. Okay, so let's just go into what is a pediatric emergency care coordinator. And I think most people are familiar with this term, but some probably aren't. And I think people think of PECCs in variable ways, and that's okay, because there's no such thing as like a complete in a box definition of what a PECC is. But again, this was introduced back in 2006 by the Institute of Medicine report. You can see a copy of that report there on the side. And it acknowledged that the pediatric needs are often overlooked across the emergency care system. And there's these large gaps. So that's everything from EMS arriving to a home, to what they get in the emergency department, to the first 48 hours of a critical illness in the hospital. There are gaps all the way across that don't always exist in adults. We're just a lot better at evaluating adults and making systems and processes for adults and tracking that information over time. And in part, that's because more adults use the system, and in part, it's because there's maybe better reimbursement for adults, and a lot of the Medicaid rules are made for adults. But regardless of the reason, there are these big gaps. So this report described the need to focus on the delivery of optimum pediatric emergency care. And one of the main goals they outlined was making sure that we strengthen the capability of the workforce to treat children. And part of that big goal was this need for pediatric leadership within EMS and EDs. And they introduced this idea of a pediatric emergency care coordinator. So the PECC role has developed over time, and the definition has also developed over time. But see, these are some of the main things that kind of fall under that role and responsibility of this person or persons. So one of the main things is making sure staff get education on pediatric topics, and that can be anything from developing didactic trainings to doing staff competencies, saying, hey, show me how you would fit a C-collar properly on a child, or hey, show me how you would figure out a weight bank or a tape bank based weight on this kid. Show me how you use the Braslow tape. Or we have a kid coming in for the anaphylaxis. Show me what you would do. And then that can move into simulation where you're really then testing, hey, pull up this medication. Let's practice closed loop communication. But those are things that can really make a difference. We know that any really sick kid adds quite a bit of stress to everyone, and everyone's brain kind of goes into frozen mode sometimes when you get that really sick kid and panic mode, and it makes you maybe not think as clearly. So if you're practicing these things ahead of time and you know where your equipment is ahead of time, those are all really important things to improve outcomes. This is also someone who oversees that pediatric quality improvement process. It's also called process improvement. And so again, that's maybe recognizing, oh gosh, we did have this kid come in with anaphylaxis and we didn't have a kit together that we could grab easily with all the drugs we needed, or we didn't know the right dose of epi that we could easily pull up. So let's put a policy in place and let's laminate it and put it on our crash cart, and the next kid who comes in, we have all our supplies together, and let's see if we have a better outcome or we have less time to administer epinephrine. So that, those are just little things that we could do in terms of quality improvement that can make a big difference. And then doing case review and giving individual and overall staff feedback is also really important. Hey, I noticed this kid got maybe 10 times the dose of something. Let's look and see why this happened and how we can prevent that next time. So this is also the development of those evidence-based pediatric protocols, and then making sure guides or your providers follow guidelines and protocols. This includes things like making sure you have the right pediatric equipment and medication stocked, participating in pediatric disaster planning, coordinating with regional EDs and EMS agencies, either on a daily basis or quarterly basis, or contributing to case review, or doing things like big disaster drills, or doing educational outreach together, and then participating in injury prevention activities. And you look at this list and you're like, gosh, this is a lot of work. And so that is one thing we recognize and we want to keep in mind as we go in and we talk about how can we support these PECCs? How can we make this happen? Because doing one of these 7 things is a ton of work and takes a ton of time. So unfortunately, what we've seen when we look at the assessment data from 2013 to 2021 is we've seen a decreased number of these PECCs being reported by EDs, especially our nurse PECCs. We think this a lot is a workforce effect from COVID. We know that a lot of our nurses were repositioned or reallocated time, or other tasks that were thought to be maybe extra were taken away, or a lot of nurses quit. And so we feel that we lost a lot of our nursing staff and who were in this position during COVID, and it has not been rebuilt. But we also lost some docs, and we know that from a workforce survey, and we're going to show you a little more data on this, about 30% of PECCs are volunteers. So it's really hard as a volunteer to be asked to do all of these things without support. And only about 1/3 of PECCs actually have any protected time to get this done. So this is some data from the actual 2021 assessment. And I know there's a lot of graphs here, but what you can see is on the top one with the kind of grayish, the EDs are broken down into their volume categories. So when we present the NPRP data, we always like to kind of try as best as we can to compare apples to apples. So we're not going to compare a hospital that sees 250 kids a year to a children's hospital. So we break it down by their pediatric volume. And then the score is right under that, and then their PECC, whether or not they have a PECC. So a physician or a nurse is under that as well. And you can see this trend that in the lower pediatric volume areas, we have less PECCs present, both nurses and physicians. And as you increase your pediatric volume, that number of PECCs present tends to increase. And again, part of that is probably because you have more resources, you have more patients that are pediatric, and so there's more of a focus on those patients, maybe some more support for that position. And then again, just those raw numbers there. This is from our gap report. So whenever a hospital or an ER takes the readiness assessment, they get this gap report, and they get these kind of immediate looks at how are they doing. If they've taken the assessment back in 2013, they can see how they've changed over time. This is the national numbers, but they would get something that looks like this for their hospital to say, do you have a PECC? And if there's a yes, they would get a check mark instead of that red triangle or diamond or whatever it is. And then they could compare them, what they said from the last time to this time. And then on the bottom, this is kind of like that, what we saw with the QI. If you have a PECC, it really pushes you. So you can see the top line are the ERs that reported both having an MD and a nurse PECC, and they're pushed way into that higher quartile readiness. So average score, probably about 90 there, versus one PECC that middle line in those boxes is kind of the mean or median. And so theirs is probably 80, and then no PEC is down maybe at like 75. And so having even at least one PEC really pushes you up into those better score categories. There's a lot of other impacts of PEC on pediatric readiness when you look at the assessment. So having a PEC improves all domains of readiness, and it's most associated with having that QI in place or the ability to do QI. So you can see, again, if you have no PEC, even the supplies is maybe the hardest one to really see, but all of these are associated with a higher odds ratio. So more likely to have these things in place if you have a PEC. So even having your supplies and equipment gets better if you have at least one PEC. The chance that you're going to have patient safety policies in place, again, that's things like having weights only recorded in kilograms or doing those triage flags. You're going to be more likely to be doing personnel training and competencies. And then most importantly, you're more likely to have that quality improvement plan. So just a little bit more data on why PECs matter, just in case I haven't convinced you. There's been other studies that have come out looking at PECs and what they're associated with. So if you have a PEC, they do these, Mark Auerbach and his team have looked at resuscitation skills during simulation, and having a PEC is associated with higher quality resuscitation skills during simulation. So again, probably these are teams that are doing simulation more often or have worked together with closed communication, and a PEC is an influence there. Having a PEC is also positively associated with having mental health policies in place for pediatric patients, and is associated with decreased rate of potentially avoidable transfers. We all don't want to send a kid somewhere if they don't need it. It's so frustrating for a family to go to an ER, wait 3 more hours, and be told they're fine and be sent home. So having a PEC maybe hopefully helps decrease the risk that that's going to happen. This is from the PEC workforce study. So Ashley Foster and her team did some in-person kind of interviews with PECs who had responded to the NPRP assessment in 2013. And this was a sample of PECs from across the US, and they acted out roles and responsibilities, and then barriers they faced and threats to their position. They had about 114 answer the survey. And again, they analyzed these by pediatric volume. Most felt they needed more time to fulfill their role. Most wanted more pediatric training. Most think it should be a paid role. And they did value the position because they felt like they were a role model and an agent for change. And then this other graph shows the week in the blue is the median hours per week spent on their PEC activities. And then the lighter blue is the median hours they feel like they would spend ideally if they had the time. And you can see the big gaps in those lower volume centers. So as you get to those higher volume centers, we looked on those slides previously, people are more likely to get a little bit more protected time, and that decreases as you go down. So we really need to support our lower pediatric volume centers and their PECs. This is just from that workforce survey again, and these numbers are pretty small, but you can see when it looks like your PEC selection, who's a designated PEC versus a volunteer, it's about half are designated, a third are volunteer, and the rest are something else. But even these designated PECs are sometimes just assigned the position. It does not mean they're given shift reduction or any other benefits. So if you look in the whiter box that says rolled adjuncts offered under that, you can see very few are actually given any sort of shift reduction or preferential scheduling or monetary compensation. Most are not given any sort of benefit for being in this role, even if they are designated in the role. So what about EMS? We talked a lot about hospital PECs. So NASEMSO in 2019 came out with a statement supporting PECs in EMS agencies. And you can find this on the NASEMSO website. And this is data from the EMS for survey or EMS for children survey that we've done through the EDC over the past several years. We have 5 data points. So the one with the blue heading shows over time all agencies surveyed. So each year we have a variable number of agencies that reply out of about 7,000-ish, depends on the year, agencies. Or there's 16,000 we reach out to, and every year we get somewhere between 6,000 to 9,000 agencies reply. But there's been a slow increase in number of PECs over time, but we're still only at 37%, even after several years of trying to push this. And then on the right is with the red header, this is looking at only those agencies who replied each time. So we've had about 2,200 agencies that have returned this survey for the past 5 survey periods. And they've done a little bit better. They're a little bit higher, almost to about 50% of these agencies have a PEC. But again, these are agencies who seem to be more engaged and maybe more committed to some of the EMSC metrics and policies. Some states have started working on how to define this role in EMS. This is a sample of the PEC role and responsibilities written up by Louisiana. It's pretty similar to some of the ED PECs, talking about supplies, training. This one talks a little bit about family-centered care, which I think is really important. Number one up there talks about staying abreast of the most current evidence, which is great. And then collaborating with their team to make sure they're submitting NEMSIS data and making sure we're getting good data submitted overall by the agency. So this is just one example of the EMS PEC role. And this is, again, kind of a definition in progress. So we really need to create sustainabilities for our PECs. That's the bottom line. How do we support these folks? How do we support this role? It's so important. We know it makes a difference. So one would be to standardize PEC training and certification. Two would be to making sure we're advocating for protected time. You can't do all these tasks without having time to do them. Trying to push our administrative teams within hospitals to make a commitment to put this person as a position, a true position within the organizational chart, and give them a title, because that also helps maintain this position. And then be able to demonstrate impact this role carries, so that we can bring that back and say, look, what we're doing matters. And most importantly, a PEC is not just someone who is on a shift, is that like, oh, this shift, you're the PEC. It has to be someone who is, like I said, has a title or has a position that is valued and is able to have time to do their work. So we need to advocate for this, and everyone on this call can be an advocate. At your own agency or your own hospital, talk to your leadership and administration, get buy-in to support PECs. And ideally, every ED has both a nurse and physician PEC. They need to be given an official title and job description. They need protected time, and we need to support them with resources. So if you're part of an academic medical center, you are a great resource, and you can be someone who shares protocols and algorithms and guidelines and can do outreach with pediatric training. You saw that most of these folks really want more pediatric training. You can help with QI support and chart reviews. So if you have a quarterly chart review with a hospital, or you get an interesting case from a hospital, you can reach out and say, hey, let's go through this case together and talk about it. And then try to minimize turnover by having a plan in place when there is a position change for smooth transition. So if you are your PEC in your hospital, having that role written out, having that title in place, so that if you do have to leave your position, someone can jump in and know what to do. So other ways to support PECs are through monthly email and outreach, scheduled trainings. Again, you can do these hands-on sessions. Everyone on this call has an interest in pediatrics and has something to offer and could lead a session. Share time and stories with other PECs. So networking is really important. If you are a PEC, reach out to your EMSC manager and say, hey, let's find a way for us all to network together. Again, case reviews regionally is a way to do some QI, regional meetings to bring people together. And then everyone is working on these pediatric recognition programs in their state. And so incorporating PECs, having a PEC as part of one of the main requirements is really important. And then I wanted to share these resources that the EIC and the PPN have recently helped put together. So if you go to the EIC website, which is down there on the bottom, they have put together information on pre-hospital and hospital PEC resources. And one of the most important things, right under where it says Pediatric Champions, there's a box, and there's a little thing that says, provide feedback here about this module. They've created these, they're in the process of creating these modules for new PECs and old PECs too, just to kind of say, what is a PEC and how do you do this and how can we support you and what's out there? So module 1 is up, and they would love for people to take a look at this, peruse through it, even if you're not a PEC. It's really interesting, and I think it's really well done. And you can see over there the kind of index of what's in this. They have a story from a fan rep about, a personal story about her own child. It talks a little bit about a PEC and the PEC role. And then this is just module 1, so there's more coming, but they would love for people to go onto that website. Again, this is a partnership between EMSC, EIC, PPN, and go through that module and give some feedback about what you think. All right, I'm going to stop there again before I just do one other quick thing. Any comments or questions about PECs?
Yeah, Irene, did you want to ask a question, or you want me to just read it out?
Sure, I'll ask it. Thank you, David. Do you have a sense of what percentage of PECs are assigned full-time versus those that do PEC duties, other duties as assigned? And just to add to that, is there a big difference between rural and urban hospitals on that?
Yeah,
thanks.
Great question. I don't have the exact numbers up there, but there's definitely a big difference. And there's a small proportion who are given a full-time position for this. And as you get into the lower pediatric volume centers, that percentage decreases. So it's kind of that same pattern where, there's probably more volunteers, less protected time, less official title as you get into those smaller pediatric centers, and more of a shared role. I feel like the people in some of these more rural hospitals, they're the PECC, but they're also the trauma manager, and they're also the, they're entering chart information, and they're probably the stroke and STEMI go-to, and, carrying like 15 different roles, and it's hard. And if you aren't assigned a specific amount of time for those responsibilities, it's really easy for other things to take precedent, or the PECC roles to get kind of pushed aside.
Any other questions from the gallery up to this point on the topic of PECCs?
I have a question, Hilary, if I may.
Yeah.
In general, for PECCs and providing education, at least for our facility, we do EMPC and NRP. I'm newly appointed. I started in September. There hasn't been any established cadence as far as providing education, like hands-on in services. Is there any research or resources that I could use for best practice in that sense?
Absolutely. That's a great question. So there is a lot of research looking at skill deterioration over time. And this is for anything like PALS, neonatal resuscitation. And a lot of this data does show, and if you reach out to me, I'll put my email in the chat in a minute. I can try to pull up some of those studies and send them to you. But most of the data shows that it starts to deteriorate within weeks, honestly, but at 6 months, you're kind of almost back down to ground zero. So most people would recommend at least every 6 months. And that's mostly for the psychomotor skills, just that muscle memory of how to use that equipment, especially for these low incident things like putting in an IO or intubating or putting an LMA in. So taking that equipment and putting your hands on it and practicing that at least every 6 months is really important. And there is evidence for that. So that would probably be the most important cadence, is at least every 6 months, getting that equipment out and using it. But there's probably a lot more benefit for more frequent things, like every month doing a scavenger hunt of where is this piece of pediatric equipment, so you know where to find it, or where is this policy, or where is that care algorithm. And that could be something that's shorter. You don't always have a half an hour to do a simulation or an hour, but you might have 5 minutes to send your staff on a scavenger hunt to make sure they know if a kid comes in seizing, where do you have this piece of equipment? Or if a kid comes in with maybe a foreign body, where do you have your McGill forceps? So you could do smaller pieces like that too in between.
Great advice. Thank you so much.
Yeah.
Let me go ahead, Mary Ann, you have a comment or question?
Yeah, no, Hilary, this is great stuff. I was going to give a couple more examples. One is that there's always a handoff for patients, in EDs, and that is a great opportunity to talk about where the equipment is. It's also an opportunity to share how to do certain types of tasks, either nursing or physician tasks. And some, in daily rounds, will have, some kind of statement where they will say, the equipment has, we now have checked the code cards, and the equipment is there for patients of all ages. Things like that actually matter because it's built into your daily workflow. And the final thing I was going to say is that healthcare corporate entities or hospital-based systems often have a regional PECC who oversees a number of hospitals, and then somebody on site who's designated the role but works collaboratively. And so that's another way to handle it in some systems. So
Yeah,
thanks.
Marianne, those are great points. And even, we every day at our hospital, twice a day, and it's with our charge nurse when they come in, there's someone assigned to every room to make sure all equipment is stocked, because there's nothing worse than a kid crumping and you don't have a bag mask that fits the kid, or you don't have what you need in the room. So that's part of, even where I work, twice a day, we have an equipment check that's passed on between every tech and nurse. And I think it's really important. That's a great point. And that idea of a regional PECC, and this next part of the presentation will touch on this a little bit too, about how we can work regionally and even lean a little bit on our pediatric centers to help support some of these ideas. So first, I'd like to say that I can't claim credit for these slides at all. These were made by someone far more crafty and creative than me, and were taken with permission from Elizabeth Sanso and some of the work that she and her group has done starting this telesimulation program. So this is focused primarily on our American Native and Alaska Indian population. And so we know that the mean weight of the pediatric readiness score in our IHS and tribal sites is lower than the national average. This is the 2013 data. We are still working with some folks to get this 2021 data published that's IHS specific. There's no specific unified intervention developed to target our IHS and tribal ED readiness across our country. And we know there's specific training needed to improve pediatric readiness in the ED setting. When you look at, Malia just shared a really impressive report looking at disparities of some of our Native populations and some of the Hawaiian, Native Hawaiian and Pacific Island populations, and the health disparities, we all know this, are really vast. And so this is a group of children who need special consideration, and we need to try to address some of these issues of health inequities that exist. So we know that overall, the AIAN population experiences lower life expectancy and higher disease burden, and the pediatric population is specifically at risk for severe illness and trauma, both pre and in hospital. And so even examples like the RSV vaccine, if you are AI or AN, you get extra consideration to get this vaccine, because if you get this as a child, if you're part of the AIN community, you have worse outcomes and higher incidence of death and hospitalization and ICU utilization. We also know that a lot of these folks live more rural and farther away from pediatric subspecialty centers, and that more difficult access to higher level care or subspecialty care is also contributing to some of these health outcomes. The majority of IHS and tribal EDs are general EDs, and adults and peds are treated in the same area, and more than half are in rural remote areas like we were just talking about. But this is a big community. You know, the IHS tribal EDs serve about 650,000 patients. That was a statistic back from 2014. And a lot of our AN population is also seen in hospitals within the same, within an area they live that are not specifically designated as IHS or tribal, but serve these communities. And EMSC is dedicated to supporting IHS and tribal healthcare programs. So Dr. Sanso and others met with leaders in the IHS and tribal EDs, and they identified simulation-based education as a need. And they said, hey, let's reach out to academic medical centers for help. And they found that there were specific barriers to simulation-based education. And those were included, not limited to, things like having the resources to do simulation. And we just talked about how important simulation can be to make staff feel comfortable and keep those skills up. Geography, time, and then the pandemic, of course, made everything more difficult. But they came up with this idea that we can overcome some of those barriers by offering a free and openly accessible telesimulation tool. So they came up with this program. It's a simulation-based education program, and the objectives are to practice pediatric emergency scenarios that were effective and feasible and sustainable. And in part, this requires having a PECC. So they went out to these different IHS and tribal EDs and EMS agencies. A lot of times everyone kind of worked together that showed interest in this program. And one of the first things they had to do was assign a PECC. And then they were partnered with an academic children's hospital. And this wasn't always even a hospital that was in their state. So places like Children's Hospital of Philadelphia has reached out to several sites that are not within their area. University of Utah supported sites that are not within their area. So is Yale, multiple sites led by Dr. Auerbach. But it's really finding an academic center that wants to partner with this PECC to make this happen. That is what successfully, because as you'll see, you don't have to actually be there in person over time. So they wanted to formalize these relationships between the academic medical centers and these IHS and tribal PECCs. And they wrote up these SMART aims, and they wanted 100% of sites had to have a PECC, and then you met regularly with your partner throughout the duration of the program. And they wanted to create a sustainable PECC co-facilitated hybrid simulation training. So initially what they did is they basically helped set these simulations up sometimes it was in person at first, or sometimes it was over simulation, and then even those in person switched over to kind of a telesimulation, where the PECC would be the one. It was kind of a train the trainer method. Over time, the PECC is the one leading that simulation, and the academic team is just in the background on the video screen as needed as a resource. And their aim on this one is to improve their pediatric readiness score by 10 points in the participating sites. They also wanted to show change in provider knowledge and attitudes and teamwork. So we know that simulation is one of the best ways to teach closed loop communication and teamwork in time of stress, and identify gaps on things like, oh gosh, we didn't have an algorithm for that, or we didn't know how to quickly pull up a dose of that. So simulation is a really great tool to use if you're able to, and then over time kind of expand this program. So that was the program that was started years ago by Dr. Sansone, Auerbach, and Robeson, and others. And I've been fortunate enough to be able to help spread this program. So we continue to use the same kind of setup. So at the University of Utah Primary Children's, we're the academic medical center leading this expansion in our area. And we got funding through the PAPN to help expand this. So over the last year or so, we've added on 2 new sites in Utah and 1 in Wyoming. And then currently we're adding 2 more sites in Utah and 2 more in Wyoming as well. And then we're going to start reaching out to Idaho. We also had a group fly up to Alaska in June 23 and meet with Seattle Children's and us and the Alaska EMSC team and start thinking about how could we support this in Alaska. And then our eventual goal is to push this out to the larger PPN as a model. And this is by no means the right model, it's a model. This is similar to a telesimulation program that's being done in Kentucky by Dr. Fallett and Abby, that's in a pilot phase, and they're doing a lot of good trauma simulation and very similar work there, where their academic team is kind of leading the charge and reaching out to their community, and they've done amazing work over in Kentucky. So that's just an example of how you can also utilize PECCs and how you can work regionally, even outside of your state, to support PECCs and to support things like simulation and education. And when we've gone, we just came back from Kemmerer, Wyoming a few weeks ago, and we went out and we did 3 simulations, kind of toured their hospital, met their team, and they had both their EMS team, their EMS office they have one EMS for the whole, hundreds of square miles area in Kemmerer, Wyoming, and their EMS station is across from the hospital. So their EMS team came in and did the simulations with us, and they have one provider there who's either an MD or PA, and then they have 1 or 2 nurses on ever at a time and a respiratory therapist, and everyone was there, and it was fantastic. And so we ran these 3 simulations, and then we sat down and we went over their NPRP assessment with them and looked at their gaps, and as a team brainstormed, how can we address some of these gaps? And some of them are easy. Some of them were low-hanging fruit, like, oh, we can easily change it so we only record weights in kilograms. No problem, we can make that happen. There's a ton of resources out there that exist. They didn't have a pediatric disaster plan or elements of pediatrics into their disaster plan, and we have those resources through the PPN and through some of the work that Utah's done. So we gave them this, and the EIC has a big disaster checklist too. So we gave them basically like this template where they just have to plug in things, and then talked about how could we drill with them to do a disaster drill that includes some pediatric components. And then we had some lunch, and during lunch just did a 30-minute didactic session on pediatric trauma concepts. And so kind of mixed that hands-on experience with a little bit of a didactic, and then that key piece of going over their NPRP assessment and thinking about gaps. And as that academic resource center, it's our job. We should have all of these things in place. We should have an algorithm for everything, and hopefully be able to share those. And if you can't share what your center has, there are places like Seattle Children's and CHOP that have really great algorithms that are available for free online that can be shared. And so for very common things like seizure, anaphylaxis, it's very easy to print up a care algorithm, laminate it, and put it onto their Broslow cart. So it's all together and easily accessible. So that's what we're working on right now. We're going down to Blanding, which is down in the Four Corners Navajo Nation on the 6th of December. That's our next site. And then kind of expanding, and it's pretty exciting. We're involving, with each time we go, we're trying to get at least 1 nurse. I see Greg on our call right now. He's one of our pediatric pharmacists, and he's been awesome and has made these medication cards, and we're probably going to drag him with us on a couple of these. And then some of our sites that have been doing this for a little bit, like I said, that the goal is this is not just a show up and leave. We try to go in person, and then ask them how often they want to do this and support them through Telesim as it goes on. And there are things like SimBox, which is an ASAP creation, and you can get these free simulation exercise. It's like it gives you the whole simulation in a package, basically, so you don't have to come up with it. We use our own simulations from our own sim team, but there are these SimBox sims that are available that anyone can use for free to run simulations. And then we also try to check in, like some of the sites, there's a site called Mountain West where once a month one of our providers joins their staff meeting and does 10 minutes of just a pediatric pearl, and then quarterly goes out and does hands-on simulation training with them. So the goal is a long-term relationship, and that people feel comfortable saying, hey, gosh, we had this case. Can you help us with this? Or can we run a simulation on this because it didn't seem to go well? Or, hey, we realized we don't have this policy or this algorithm. Can you guys help us with that? And we want that back and forth communication. And we want to empower the PECC to be the one who's really in charge of these simulations and these trainings and feeling like they're the expert and they're the go-to. So that's the goal of this program. Again, this is a program. It's not the right program. It can be adapted in any way that works better for where you are. But just wanted to touch on that. And then just last, this is a resource that was shared by Malia out of Seattle. If you want to look at some more things on data equity, this was a really cool tool where you can plug in your state and you can pull up things like uninsured rates. There's a bunch of different categories. There's like economics, health, housing, and you can pull up different things that they all affect health, right? This is all part of global health equity, but you can look in your area what you're seeing. This is probably one of the better data tools out there. I've done a lot of search. There's one with CMS that you can look by things like medical condition, but the problem is it's all adult based. I mean, the only categories are like less than 65, and then there's like 65 to 70, and it's all pretty adult based. So it's not very helpful for breaking it down by kids. There's one that you can pull up where you can find all the different tribes in your region. If you're curious about what tribes exist in your region, that's another cool one. But this one seems to be a pretty good one. So I will stop talking now and let Marianne have some turn too. And thank you guys so much for listening, but jump with any questions you may have. Let's share some resources too.
Hilary, thanks. That was outstanding, as always. I have a question for you, if you don't mind.
Yeah.
I know we have like 10 minutes left or so, and I think others are going to have some questions, but where do you see the future going? One of the things that has come up over and over again is that no one hospital is ever going to gain the experience that you see in a children's hospitals, because that's all they're seeing are kids. And even then it can be a challenge depending on the volume. Do you ever see something, going forward for really real-time consultation services, kind of like what they do with Telestroke or Telepeds, in which there would be literally real-time consultation?
Yeah, I think that's a great question. I think that is part of the future. I think the infrastructure is still young, but a lot of places are implementing that. And I can only speak for my area. And we are modeling our system. I think it is after Philadelphia, but we're calling it the quarterback system. So we currently have telehealth consultation available either over phone or by video. We are part of the Intermountain Health system. So at this point, it's really through just Intermountain Health hospitals, but that's 20 plus hospitals in our region. But it's expanding, and our trauma team is also expanding trauma consults, and we have PICU consults. So, the other day we actually had a child in full arrest, and they called, and the PICU doctor was there on the video trying to help this hospital figure out why they couldn't get this kid's heart started again. So it's just another voice there helping. I had one where there was a little baby who was seizing, and they'd given Ativan, but the baby became apneic, and they were trying to intubate, and they couldn't get the tube in. And so I had my respiratory therapist and my pharmacist and myself all sitting there on video giving hints, and they were able to get the tube in the second time. And so I think that really is the wave of the future, but it takes a lot of infrastructure in place. So I think at the very least, having the ability to call at this point, so having a relationship with a children's hospital, you could at least call while we're getting the video components worked out is helpful, because I think there's a lot of we had to get licensed. We're now licensed in Montana, Colorado, Idaho, Wyoming, and Montana in my group because of the telesim work. So I think that just takes time. But until then, at least having, if you can make these relationships where you feel like you can just at least call, that's helpful.
You know, I'll see if I don't see any questions in the chat, but please feel free to just unmute and ask a question if you have one. I'd love to hear, well, there's several things. One is all hospitals need to have community benefit, especially those who receive disproportionate share funds. And so that it is an opportunity for children's hospitals who all get that to create projects such as these that are truly community benefit. And that is looked upon very favorably to get additional federal funding for hospitals. So I don't know if you're aware of that, but you kind of brought up that you're going in all these different sites, which is really a heavy lift and should be applauded. All right, I'm going to have an ask of the group. If you had your wish, what would be the next steps for EMSC and the Innovation and Improvement Center and the EDC? What would be a resource that you think should be available so that you could do a better job?
We can take it. Throw anything you have at us.
Yeah. Do you feel that online clinical pathways would be helpful for you, as an example? You have a silent group. Let's see.
Can we call out?
You know what happens when nobody speaks? Then
We're going to find someone we know.
Nobody
Yeah.
speaks, then I speak up. We'd also love to hear, you can put it in the chat, any suggestions for the next quarterly educational session, even suggestion around speakers that we could invite to participate. Other than that, we will, Hilary, with your permission, make the PowerPoint at least available in a PDF for viewing, and
Absolutely.
the video will be edited and placed. You'll need to be able to log into the RAPM website, but it'll be also posted up there. So for replay back or to share with colleagues that weren't able to attend.
David, real quick, let me put in the link to that PECC module, because that is one way you can answer Marianne's question without having to do it in front of everyone. But if people want to look at that first PECC module that has been put together and give some feedback, you could say, hey, this was great, but this is also what I would like to see. Or could we add some more information about, this or that, or this is what I really need in my place. But let me put the direct link that's on the PPN website that'll take you right there.
And one other ask, thanks Hilary for doing that, is if there are particular clinical topics, and obviously we want to make them relevant for nurses as well as physicians. If you have any other thoughts on that, you can email Dave or myself, and I will put my email in the chat, because there's really a lot that we can do, and maybe this can build a little bit over time as people get used to a quarterly offering.
And we really do, we're all part of the same mission, right? PPN, RAPM, EMSC, EIC, EDC, we're all trying to work together to improve care for kids and to improve readiness for kids. So please reach out to all of us. We all join meetings together and can pass things along. Let's see, Justice wrote, does the EIC anticipate offering an EMS version of the PECC module? Yes, that is my understanding, is they're going to try to finish some of these ED focused PECCs, but they're also the PPR group is working on resources. They currently have a checklist. If you go to the EIC website, you can find the PPRP checklist and toolkit for pre-hospital readiness that you can access now. And then they will be making modules for pre-hospital readiness as well.
And, just for all those pre-hospital people out there, the assessment will be next year. So look for that in May, actually before May, but May is the assessment for the pre-hospital pediatric readiness assessment.
And we're going to count on all you to help us get the word out about that assessment and help promote it so we can get a good response rate. It's the only way we can really know the current state of readiness in our pre-hospital setting is getting that high response rate. And it's a challenge. Everyone's burnt out. Everyone's tired of surveys. We know that, but it's so important.
Hi, this is Irene. Two documents that might be helpful to existing PECCs or people who are providing training and resources. We have the Surge Playbook that's been developed by RAPM, and we also have a document that was developed a couple of years ago, the just-in-time training manual. It's for non-pediatric doctors to get sort of pearls and techniques for treating pediatric patients in difficult emergency disaster conditions. And that was done through our deployable assets focus group. So that document is ready and available. It's been distributed widely previously, but I don't know if we targeted PECCs or PECC trainees specifically, but it may be of good use. Thanks.
Great idea. Thanks, Irene. That was great information. And there's so much out there. What I want everyone on this call who is a PECC to know is there's so much that exists, and you do not have to recreate anything yourself. If you need an algorithm, or you need a training, or you need something to boost your disaster planning, we have all of that for you. So reach out to anyone on this team and we can help get you what you need.
Good afternoon, everyone. This is Cherie Lowe with the California Hospital Association. Sorry, I'm not on screen, but I just wanted to provide a little bit of clarification about the statutory rulings related to community benefit plans, because I don't want folks to think that every hospital is required to follow the code sections related to community benefit. That is limited to private, not-for-profit hospitals only.
Oh, okay, that's helpful, because I thought it was those who received disproportionate funds.
Yeah, many people are confused by it, so please don't, just know that it is just for not-for-profit private community or hospitals.
Thank you.
Thanks for that, Tree. Appreciate it.
Sure.
Any other comments or anything else we can do for you guys before we take off? We appreciate everyone listening in and your attention. I know everyone's time is precious, so thanks so much for joining today.
Thanks, Hilary. That was really fantastic overview. All right, and Dave, thanks for organizing. Appreciate it.
With that, we'll schedule the date for our next one and the topic. Appreciate everybody joining us today.
Thanks, everyone. Have a good Thanksgiving.
You too.